Good morning, Dr. Ivana.
Good morning.
Good morning, good afternoon, and good evening to one and all, in whichever part of the world you are sitting in. Today's our speaker is a very dynamic young orthodontist. She has done a lot of cases with the Invisalign, and she would be sharing us the digital treatment planning, which is actually a tool to decide the proper treatment planning. So without wasting much time, I would just, by the way, this is Dr. Ivana, very good to have you on our 50th webinar. We
Thank
have
you,
been
glad to
working.
participate.
Thank you. It's a pleasure to have you on our 50th webinar. And it's really great to have you are from the center, like center of the earth. You're talking and we have people from across the globe attending to you. Dr. Ivana has received her dental degree in 1998 from the Dental School of Aristotle University, Thessaloniki. She then completed her 3 years orthodontic specialty at Eastman Dental Center, University of Rochester, New York, where she also received her certificate in TMD in 2002. In 2011, she completed her PhD thesis entitled Cephalometric Indices of Biological Response to Orthodontic Treatment in Children with Class 2 Division 1 Malocclusions in the orthodontic department of Aristotle University, Thessaloniki, from where she did her graduation as well. She has published numerous articles in world-renowned journals and is a regular lecturer in conventional and seminars worldwide. She maintains 2 private practices in Macedonia, Greece, and is certified Invisalign provider since 2001. Her main clinical interests are growth modification, digital orthodontics, and Invisalign treatment of adolescents and adult patients. She is a member of American Association of Orthodontists, World Federation of Orthodontics, Greek Orthodontic Society, Greek Association of Orthodontic Study, and a research here to you. And she is also a member of. Over to you, Dr. Ivana. Thank you for joining in.
Thank you. It's a pleasure and it's a big honor to be with you. 50th webinar and having colleagues all around the world. So it's one of the good things that came along with coronavirus crisis, which I hope eases out in all countries. And right now Greece is, has lifted the lockdown, so we're in a lockout, and hopefully people can come and visit. So good luck with everyone. And let's start our webinar, which has to do with digital treatment planning. And mainly we're going to discuss how to look at a ClinCheck, so how to look at the algorithm of Invisalign during treatment. So just a few words, and I got already the introduction. So I come from Macedonia, that's the northern part of Greece. Katerini is a small city, about 60,000 people. Greece is a small country. We are only 11 million. So Thessaloniki is just an hour to the north, so it's around here. And this is where my university, the Aristotle University of Thessaloniki, is situated. We don't have Mount Everest, but we have Mount Olympus, and it's the highest mountain in Greece. So this is the summit, or close to the summit. It's 2,917 meters, a very nice place to visit, whoever wants to come and hike along. So Greece has a lot of mountains because mainly we're thinking of Greek islands of Mykonos and Santorini and Crete, but we do have snow. We do have also rivers, if you like rafting, and of course we do have the sea. So June is here, and I wish you all have an uneventful summer. This will be a weird summer for everyone. And let's get started talking about teeth and occlusion, as we orthodontists are good at it. And we're so used to doing things with conventional appliances like braces, but we do have another tool, because that's what Invisalign is. It's a different tool for the orthodontist. And so we're going to talk about aligners. And there are quite a few advantages as far as aligners are concerned. And I've seen it even more now with the lockdown and patients not being able to come to our practice. So we were able to keep, monitoring our patients virtually, especially with aligners. They can switch their aligners usually weekly. So they didn't have any stall during their treatment. But I want to underline that virtual appointments are a nice thing. But I definitely want to see my patients in the practice and to make sure I have that personal contact. And we're not only, moving teeth, we're also checking their oral cavity, even for lesions. So I would definitely think coronavirus taught us a lot, but we shouldn't forget, the science behind it. But apart from that, Invisalign and aligners have, as I said, a lot of advantages. So they are removable. So we see a lot of good hygiene maintenance with our teen patients, our kids for Invisalign first, and our adult patients. They're quite comfortable. They're customized, as it says here. So we are providing aligners that are individualized to our patients. It's a very nice aesthetic treatment. It's non-invasive, so we don't have emergencies. We don't have breakages. The worst thing scenario is losing an aligner. So they can just switch to the next one. Invisalign uses 3D computer modeling to provide that treatment. And one of the main, I would say, advantages is that you can actually, as we will see, showcase and show your patient your ClinCheck. So they fully understand what their malocclusion is, what your treatment plan is, or what the different options are, in order for them to better understand what you're proposing. Because they are seeing, they're not imagining things as we're doing with braces. And I was trying to, explain how their canine will be corrected or their overjet corrected. Now they can actually see it on the screen. And last one is that, yes, they can see how their occlusion is progressing, and they don't have to imagine how their final smile will be with all those braces on. On the other hand, we have to be careful, because that's exactly what's happening. Patients are monitoring their treatment because they're taking the aligner off, and they can definitely see how their teeth look like. So if we haven't planned our treatment correctly, they will, let's say, see the mismatch on the incisal edges in the beginning. So we have to explain to them how their teeth will progress, since you don't want to have any conflict with your patient. And I would definitely think it's a good thing to have your whole team on board, especially when it's a new tool in your practice. So if you're mainly doing braces and you want to move into digital treatment planning and aligners, your receptionist, your treatment coordinator, or your assistants have to be on board and understand what the differences are between the two systems. So just briefly discussing about what's the procedure to start with Invisalign. You can either take impressions, or what we do is we scan our patients, and it's a very useful tool. And I would definitely think it's the way to go. And maybe we can discuss that later, scanning our patients, and then just uploading their file, their STL file to Invisalign. And after we upload our records, meaning our x-rays, our pictures, and the scan or the impressions, then Invisalign will, according to our instructions, create a ClinCheck, so a virtual treatment plan. Then you will have to monitor and do all the changes that you have to apply. And this is the actual question I would like to answer. Why are we doing this webinar? So the answer is what we need to know to modify the ClinCheck. And after we're done, we approve the ClinCheck. And this is something that you cannot, take back. So once you approve, the aligners are going to be fabricated, manufactured, sent to the practice, and then the patient comes and we start with the treatment. So what we need to know about the ClinCheck and what we need to know about the whole process, we're going to discuss initially on how to evaluate the first ClinCheck that you see, meaning that you will have a video playing, and sometimes it might be a little mesmerizing or frightening to see, teeth moving. So we have to be able to evaluate, is the initial ClinCheck reliable? Is this something that has biological meaning? So we're going to discuss how to pick up any unrealistic movements, because it's a different thing to watch something on the screen, and it's a different thing to actually apply it on your patient. And I would think that's the most important thing once you take that step into the digital world, to differentiate what's virtual and what's clinical. And we definitely are clinicians, so we want to make sure what we are proposing is going to have an effect, a clinical effect on our patient. We're going to discuss about the tooth movement table, because with Invisalign, you're able to see where your tooth, every tooth is moving, degree-wise and millimeter-wise. We want to modify our staging, meaning that there are different ways to, let's say, treat a class 2 to a class 1. Are you going to distalize the whole segment? Are you going to distalize one tooth at a time? So we have to make sure we have a staging that is very predictable. Attachments are a big chapter. It can be just a webinar on its own. So we are going to touch about attachments and how we're going to change them to make all those teeth move in a sound way. We want to have actually a virtual treatment plan in our own mind, like we're doing with all our patients. So let's say again, in Greece, we have a lot of class 2 patients. So once you're distalizing, you want to know that, let's say in 6 months, you want to have a class 1 molar relationship. And then in 9 months, you might want to have a class 1 canine relationship. And if this is what you're seeing on your digital treatment plan, you have to see it on your patient. So you must anticipate any timeline, milestones, and be able to monitor that those things are actually happening. So if we can apply all those things, we will have a more efficient treatment plan, and thus we will have a certain treatment for our patients, which is not only good for our management, for our practice, it's also biologically acceptable for our patients too. And I think that's the best advertisement you can have. So this is a ClinCheck. So this is a tough case. We're not going to discuss the case, but I just wanted to share it with you. So this patient doesn't want to have surgery. He doesn't want to have extractions. He's a patient that lives far from my hometown. So I'm going to monitor him virtually and maybe have a few appointments, mid-treatment. But is this going to work? Is this a treatment plan that is actually having an orthodontic meaning? So we're going to discuss how to be able to see all those things and make sure you apply them. So first thing a ClinCheck gives you is the actual initial malocclusion. So think about it like having plaster models. Instead of having your plaster models, you just take a look at your digital study models. So you have to make sure that what you see, as I say here, initial malocclusion, is the actual initial malocclusion of the patient, meaning that sometimes we might have a difference between what we take as a bite and what Invisalign will upload. And usually you might get a message from your technician saying, we have a discrepancy between your pictures and, let's say, usually not your scan, usually your impressions, because with a scan, we're safer. So make sure what you see as your stage 0, meaning the first stage that you see on your ClinCheck, is the actual status, initial status of the patient. Otherwise, you're treating a different malocclusion, so you're treating a different patient. Always make sure you have your initial malocclusion as it actually is in reality. The other thing that we can have from the ClinCheck is that we can visualize the final tooth position, but I do have an exclamation mark there, because we have to think of the ClinCheck as not tooth moving, but actually not teeth moving, but it's actually the difference in the shape of the aligners. So the aligners change shape as we progress into treatment, and that's what you're actually seeing on your ClinCheck. So what you see at the end is not the actual final tooth position, but the final forces acting on the teeth. That's why sometimes you might see some ClinChecks looking a little awkward or a little weird at the end, because we want to overtreat. Let's say I have a very deep bite patient. if my final ClinCheck looks like perfect with, let's say, 1.5 millimeter overbite and overjet, I probably might end up with a deeper bite than actually I desire. It's the same as putting a reverse curve of Spee on your lower wire, because you don't want to have a curve of Spee that is obviously that exaggerated at the end, but you know you're going to lose some of the force that you're applying. So final tooth position for the ClinCheck, think about it as the final forces that you want to exert on the teeth. So you might want to exaggerate a little bit, and that comes with experience. So open bite, yes, you might want to over-treat it into a deeper bite, or deep bite into a 0 millimeter, let's say, overbite. But there isn't any cookbook, so I cannot give a general advice. I would definitely say that try to think orthodontically and apply all the principles you have learned from dental school and your specialty, enabled to have so as to have a good final result. Another tool that we can use to evaluate our ClinCheck is the intra-arch symmetry. So we can definitely open our ClinCheck and see our upper arch and our lower arch. Make sure we don't miss out on any dental or skeletal symmetry. And of course, and I would definitely underline that, it's the responsibility of the orthodontist to treatment plan and not of the technician. So I'm not just throwing, the ball to my technician on the other side of the world in Costa Rica saying, you know what, just give me a class 1 occlusion and give me a perfect overbite and overjet, because they don't have orthodontic training. So you are the one who's going to decide, is the asymmetry, let's say, of the arch dental, skeletal, and you're going to dictate the treatment plan. Now we can definitely take a look at the buccal segments during our ClinCheck evaluation. We can check our crown teeth, the torque, because this is what the patient will see upon smiling, right? So when I smile, I can see all the torque and the tip of my teeth. And again, in my home country, we do have narrow upper arches. So I do want to broaden the arch and give a better torque on the buccal segments. So I do want to make sure initially how they look like, and finally how I'm going to treat them, and obviously have all those biological limitations as to how much I can expand. Midlines and curve of Spee. Here you can see that there is a discrepancy between the upper and the lower midline, but again, your technician doesn't have the knowledge or all the information or the responsibility to know which midline is on facial midline. So what you want to say, for example, is that, you know what, my facial midline is 2 millimeters off the upper midline. So I do want to shift my upper midline to the left and not my lower, to the right, I'm sorry, and not my lower midline to the left. Otherwise, if you just ask for midlines to be coincident, you might end up with dental coincidental midlines being symmetrically off your facial midline. So always make sure you take a look at your pictures, like treatment planning for a usual patient. Curve of Spee, as I mentioned before, we want to end up with level curve of Spee, and sometimes we might need to over-treat it. So you always have to take a look at your curve of Spee with your models open. So make sure you evaluate it correctly. We can definitely do 3D changes in all 3 planes of space. So we can ask for AP, for anteroposterior changes, for sagittal changes, for vertical changes, and you can definitely visualize all those in the ClinCheck. And of course, you can have different treatment plans, and I would definitely suggest you take advantage of that, because right now you can even have a very easy case or maybe a light case, and we're going to discuss a light case later, and you can have different treatment plans. So even if you are not sure which one to propose, you can definitely ask, let's say, for an extraction case, or for the same patient, you can distalize, or maybe you can, let's say, expand and do IPR, do different treatment plans, and, actually talk to yourself and see which one you feel it's more predictable, and maybe share it with a colleague if this is a multidisciplinary treatment, which I always do, so we're on the same page. And then at the same time, share it with your patient. And I can discuss with my patient what the advantages or disadvantages are for, let's say, a class 2 extraction case or a class 2 distalization case. So the patients can have a visual outcome and they can take, I would say, a more informed decision. There are a lot of automatic tools that come with a ClinCheck, like Bolton discrepancy, which is a vital, I would say, parameter to monitor. We have the superimposition tool to make sure that we know where the teeth are supposedly moving in space. And also we can have simulation for surgical cases or for elastic simulation or for, let's say, a vertical bite jam if we have an open bite case. And last but not least, use your ClinCheck as a communication and educational tool for your team, for your patients, for your colleagues, or for anyone that you want to share your knowledge and communicate what you want to treatment plan. So I do think using the ClinCheck as a tool will cut down on the miscommunication we might have or misunderstanding we might have with a patient that doesn't have the orthodontic knowledge. And sometimes we do have a very nice treatment plan in our mind for our fixed appliances patients, but the patient doesn't really realize what you're talking about. Sharing a digital treatment plan really gets them, I would say, in the game early on. Now, of course, proper diagnosis has to do with all those, parameters. So we take into consideration our facial aesthetics. Do they have a gingival smile? Is it a perio patient? Do I have any limitations as far as my PA cephalogram or my Panorax is concerned? Do I need to modify growth, or it's an adult patient? Of course, the age, any underlying conditions, if I'm going to accept any compromises, and if I have any time constraints, all these have to come into play to have a good diagnosis and treatment plan. But this is not what we're going to discuss about. So everyone in his or her practice are doing their best for their patient, taking those into considerations. But what we're going to focus today is on biomechanics for aligners, which are a bit different, again, as I said, with fixed appliances, where clinical is what we see every day, because our bracket patient will come and every month I will adjust and make corrections, having, of course, a treatment plan in my mind. But with Invisalign, I am actually working around the virtual treatment planning. So I have from start to finish to do a nice treatment plan. Otherwise, I will keep, rescanning my patient or retaking impressions, and that's very frustrating for both the doctor and the patient. So try to think ahead and try to think about all those biomechanics that you have learned and apply it. So your treatment plan will be, as I said, realistic and predictable. And I would say there isn't any first ClinCheck that I can approve. I always have to make changes. Now, Invisalign has a lot of information on Invisalign Academy, and there's also a quick start guide, which is quick, but it has a lot of valid information. So biomechanics, as we said, with aligners are a little bit different. And again, as a reiteration of what we said, always have to review the initial bite. What I do when I get my first ClinCheck is after I see that this is the actual patient, this is the initial malocclusion, then I run the ClinCheck, so I let the video play. Then I take a look at the staging, as we will look at it later on, to make sure that what I see is predictable. So after I make sure that those movements are predictable, I use a superimposition tool because it gives you a visual, understanding of where your teeth are moving 3D in the upper and the lower arch. I always evaluate the attachments. And as I said, we're going to touch on that subject and make sure those attachments will do the work that they are being there for. Anchorage is a big issue. And I think one of the most important things to understand with Invisalign is that anchorage considerations are not usually built in your ClinCheck. So whenever I'm moving a tooth, there is an action and there is a reaction. So Invisalign thinks, and the algorithm is really helping you with the action of the tooth. But what the action is causing as a reaction, you have to think about that. So if I'm, let's say, intruding a tooth, am I going to have a misfit of the aligner on the neighboring teeth because the aligner is going to be, let's say, extruded on those teeth? So you will have to think about anchorage yourself. It's not usually incorporated into the ClinCheck. Now, talking about reciprocal movements, I mean movements that you can consider asking for at the same time, and they will definitely happen. So when I'm distalizing, let's say my upper molars, I can definitely ask for incisor proclination because it's the reaction of the aligner as I'm going to distalize my teeth. But if I'm trying to distalize my whole upper segment, and sometimes you might see it on a ClinCheck, this is something that will never happen. How can you do it with fixed braces? Can you distalize the whole segment unless you have TADs or maybe plates? So try to think orthodontically. IPR, and I do a little bit more IPR with my Invisalign cases than with my fixed appliance cases. And that comes with the fact that you do have collisions, meaning teeth having very tight contact points. So with aligners, sometimes it's really hard to counteract that. With fixed appliances, friction is not that big of an issue. So you might want to apply some IPR, or what I advise you to do and what I advise my patients to do is use floss. So every time my patient brushes at night, I always tell them use your floss and make sure you don't have very tight contact points. And if they do see that, they might need to come to our office and make sure we might need to do some minor IPR. But I don't think IPR is the way to go to treatment plan a case or to avoid extractions. So again, biomechanics and the biological principles are there. They're just different with aligners. Now, auxiliaries, we can use different types like elastics, or you can even use buttons, or you can use TADs. It's up to you. You can be as creative as possible as you want. But how at least I started in my office is I started with very light and minor cases, building my expertise and treatment planning different cases after that. But I would think starting with, let's say, crowding cases or spacing cases and maybe class 1, it's the way to go. And then as you become more proficient, I think you can probably treat, if not all, most of your cases with Invisalign, if that's what you're aiming for. And finally, we also want to take a look at our occlusal contacts, which is another big factor to consider. So let's say you have a deep bite patient at the end, you do want to have heavy occlusal contacts on your posterior region. And that's because, again, you don't want to have a very deep bite when you finish. So as we will see on our ClinCheck, are going to check the bite, run the ClinCheck, and do our attachment evaluation, do our occlusal contacts, and at the end, over-engineer, meaning applying more force in order to have the final result. So maybe overcorrecting a deep bite, overcorrecting an open bite, like you would do with your normal fixed appliances in order to achieve your goals. Now, before we dive into the 2 clinical cases we're going to discuss about, I do want to mention the attachments. It's a very big chapter, and it's a very big advantage, I would say, of Invisalign, being able to give you the optimized attachments. It's one of the 2 categories. So we have the optimized and the conventional attachments. So optimized attachments, they come automatically with the software. So you don't need to ask for those. If there are different, movements of your teeth that are above a threshold, let's say rotation or extrusion, you will get optimized attachments. They're usually very aesthetic. But sometimes when we have a lot of movements happening at the same time on one tooth, an optimized attachment might not be the answer. So there you can use conventional attachments. Now for conventional attachments, you have to place them yourself, or you can type in on your clinical preferences. Let's say if I have more than 5 degrees of rotation on my upper incisors, please always use vertical, let's say, attachment. So conventional attachments usually are placed by the doctor. There are a couple of cases that Invisalign will place them for you. And one of these exceptions is if you have a lower incisor extraction, you will automatically get conventional attachments on either side of the extraction side. But apart from that, conventional attachments are for you to place and sometimes to replace the optimized attachments. And there are different preferences for different clinicians, as I hear. And again, we're going to touch on that. And always remember, when we are using, obviously, our first template to apply our optimized and our conventional attachments on the teeth. But let's say a patient pops off an attachment during treatment, an optimized attachment. Please make sure you use your original template to bond that attachment, because if you try to look at the picture here, I have a very small looking optimized attachment here, and look how big this optimized attachment looks on the actual active aligner. And that's because the attachment, the optimized attachments have active surfaces. So once you bond them, their shape on the active aligner will change in order for the forces to be applied on the active surface. So if I'm going to use this active aligner, let's say this is aligner 15, and the patient comes in the office and they say, you know what, I've lost the attachment on tooth 35 and I'm on stage 15. So if I'm going to use aligner 15 to bond this attachment, I will end up with a huge optimized attachment here, bigger than it was supposed to be. So I'm going to have interferences. I have two ways to circumvent the problem. One is if the initial template doesn't fit because your teeth have shifted, you can just cut the initial template, fill it with the resin that you prefer, and then bond the tooth. The other thing you can do is, we usually do that unless there is a big emergency. So let's say the patient again comes and they're on stage 15. What I do is I just, for free, and Invisalign gives you that option, you can ask as many templates as you wish during treatment. So I can order, let's say, template number 17. I ask my patient to come back to the practice. 2 weeks after that, he will be on aligner 17. So I use template 17 and I just bond the correct size of the attachment. So always remember that. Don't use your active aligner to rebond a failed attachment. You can definitely use your active aligner to bond, let's say, this attachment, which is a conventional one, because the shape of the attachment is exactly the shape of the reservoir you have here on your active aligner. This is also a very important fact, a very important page to consider. And this again is on Invisalign Academy, and you can definitely look into it. But we have to make sure to realize that our teeth usually move in all three planes of space. So they are doing very complicated movements. They're not just extruding, they're not just rotating, they're not just torquing. They might do all those things at the same time. So the software has to distinguish which movement is, let's say, more important and place the attachment that is more appropriate for that movement. I'm not to say that this is the always correct hierarchy, but this is the hierarchy that Invisalign uses because, as I said, the software has to choose between those attachments. So when the software takes a look at movements, the first hierarchy is, do I have any group movements, any teeth moving at the same time? So do I have a premolar extraction? Am I extruding, let's say, my upper incisors at the same time? So if I'm doing that, I will get attachments, let's say for my premolar extraction, my G6 attachments, or if I'm going to extrude my incisors, I'll get those optimized extrusive attachments on all my upper teeth. It doesn't matter if my upper incisors are torquing, are rotating, are tipping, I will just get my extrusion attachments. So if you want to, let's say, torque your incisors before extruding them, then you might want to type into your technician, please torque my incisors using, let's say, my aligners. And then after you do that, please make sure that you put your extrusive attachments, or if I'm tipping the roots of my incisors, please, let's say, use my twin attachments to tip my incisors first and then extrude them. That means that you will need more stages. So as I said before, if you want to use your power ridges initially, on your aligners to torque your incisors and then let's say extrude them, that might need, let's say 10, 15 more stages. It will take you more time, but it makes it more predictable. Or the other thing you can do is just use your conventional attachments. So hierarchy number one, the first attachment that you will see is the attachments that are being placed for groups of teeth, extraction or extrusion. Now hierarchy number two is root movement. So if I'm going to have my mesial and distal movement of my roots, I will usually get those twin attachments. Hierarchy number three is I'm going to have attachments for rotation or for vertical movements. As I see here, anchorage for intrusion is number 4. So it's way down. And as I said, anchorage is not a parameter that Invisalign takes into consideration per se. You have to take it into consideration yourself. So if I'm going to have, let's say, a very deep bite, and I would want to get my G5 attachments to be able to control my intrusion of my lower incisors, and at the same time, I have some rotation of my premolars on my lower teeth, guess what? I'm not going to have my G5 attachments for intrusion. I'm going to have those small attachments for the rotation of my premolars, and I might see some misfitting of the aligners as my premolar actually is not tracking. So you will have to think about which one weighs more, your anchorage for your specific deep bite case or your derotation of your premolar. But again, that's the hierarchy. And last one is a power ridge for lingual root torque. And because right now, I guess for manufacturing reasons, Invisalign cannot have power ridges and buccal attachments at the same time. So you can have either of them. You either torque the tooth or maybe rotate it or tip it. So make sure you have that in mind every time you see your movements on your tooth movement table. This is a hierarchy that Invisalign will apply, but you have obviously the freedom to, move up and down in this hierarchy and ask your technician to use different attachments if your treatment plan asks for those. But you have to consider that yourself. So let's move into our first clinical case, which is an older case, but have learned so many things from that that I wanted to share it with you. So this is a growing patient. At the time, he was 16.5 years old with an anterior crossbite and very heavy gag reflex. That's why you will see pictures a little bit fuzzy. And back then we were taking impressions. So that was also a little bit of a nightmare. But eventually he got more used to it, and you will see the impression material. The good thing is that he was able to bite end on. So he was actually shifting, and this is a good thing to consider. And I actually, inform my technician about that he's shifting forward, but his habitual bite was in class 3. Shy patient, so his smile was, a little bit shy here. And definitely we wanted to change how his profile looked like. And I did want to make sure to increase here my nasolabial angle and improve my lip prominence, my upper lip prominence, and just tuck the lower lip a little bit back. Obviously, we weren't talking about surgery. He had some dental work to be done, and his third molars, and for Greek parents, telling them that their kids need to extract her molars is a nightmare. So you will see he extracted them after the end of treatment. His pan was non-contributory, and you will see his lateral ceph, strong mandible. And again, this is his habitual occlusion shifting forward. And I did want to, improve his nasolabial angle. And as I said, have a better balance on his lips. So just by looking at the x-ray, I just wanted to make sure I advance his upper incisors and maybe retrocline his lower incisors, but not that much because of the bone. And I'm telling you this because we will see our first ClinCheck here. And this is the first video that came from Invisalign. And always please make sure that your technicians follow your instructions, because here the technician didn't follow what I said. And imagine that he's just retroclining and retracting his lower incisors like a ton, doing a lot of IPR on a growing patient. And actually what you will see is that for his mainly, look at all at IPR, they even put bite ramps on the upper teeth, which didn't make any sense. And for a patient that I want to advance his upper incisors and improve his lip prominence, this actually is not helpful. Using the superimposition tool, the technician was actually retracting my upper incisors and very severely retracting and retruding my lower incisors to correct that class 3 malocclusion. And look at all those contact points. This is definitely no sign, because you're going to end up with a posterior open bite having those tight anterior contacts. So obviously, you are responsible to make sure to understand that this is unrealistic, and this is our tooth movement table. And if we're going to take a look at the lower, you will see that I have a translation of, let's say, 3.5 millimeters lingual movement of my 42, and at the same time that tooth is also getting retracted, retroclined 7.7 millimeters, meaning that probably this tooth is coming outside the bone. So this is not only unrealistic, this is biologically unacceptable. So once you approve it, you are responsible for that, not the technician that misunderstood what I was talking about. And as I told you, the technician used bite ramps in the upper incisors, which didn't make any sense, because what I said is, can we use something like the upper bite ramps for the lower incisors? But I guess he didn't understand what I was talking about, and he just placed the bite ramps in the upper arch. I just wanted to have, a bite block effect to be able to jump the bite. So this is what the actual first ClinCheck looked like. And as I said, huge retroclination and retraction of lower incisors. And if you take a look at his bone here, you can definitely see he has a very thin gingival biotype and his roots are protruding. So imagine what will happen if I was going to approve the ClinCheck and bring those teeth back. I would get recession everywhere. And I don't want to even think about the aesthetic result on his face. So if you want to communicate correctly with your technician, I would suggest if you cannot change it in 3D controls, and again, that's, as I said, an older case, and we have more freedom to change things right now on our own, but it's not a bad idea to just explain your thinking. And if you have a tooth that you like, its initial position, let's say here I like the tooth 12, I just tell them, and I'm just going to stop it so it won't be confusing. So I just ask my technician, please use tooth 12 as reference because I like its initial position. So please procline the rest of the incisors to make, a symmetric arch and then match the lower incisors. And that's a general instruction. After the next ClinCheck comes up, then you will be able to work more around it. But use a tooth as a reference, or if you have a lower incisor that you don't want to procline because of gingival issues, you can definitely ask for that. Don't procline my 41, let's say, more than 5 degrees. I asked them to remove the bite ramps on the lingual side of the upper incisors because they didn't make any sense. And this is something that I learned from a clinical support of Invisalign, because you can make, phone appointments, especially in the beginning. And there are a lot of good clinicians or technicians that will give you technical advice. So one of them I told them that I want to have some bite block effect on the posterior region, so I won't have that traumatic occlusion, those teeth, colliding as I'm trying to correct the anterior crossbite. So they suggested I put some attachments on the occlusal surfaces of the posterior teeth, as we will see later on, that I'm not going to bond. So those are just attachments on the aligners. I'm not going to put any resin, and I'll use them as bite blocks to open my bite. I also tell them, please close any upper spacing via mesialization. So I don't want to retract my incisors. I want to protract my posterior teeth and move them mesially. remove all IPR. I don't want any IPR on the lower arch. I did have spacing. So just use the spacing to just retrocline my lower incisors. I put my upper limit of retrusion to 3.5 millimeters, which is a lot. But again, I wanted to have that as maximum and see how my second ClinCheck will look like. And I'm going to use my class 3 elastics. So once you're using elastics to, as auxiliaries to back up your movements, you do want to have attachments on the teeth that you're applying your elastics, especially when you're having precision cuts and not button cutouts. So I asked my clinician to put, my technician, sorry, to put attachments on the teeth that I'm going to put my elastics on. So again, we always have to have in mind our initial smile of our patient, our profile, and then take a look at their teeth to make sure that we provide them with the best treatment plan possible for their own needs. So this is ClinCheck number 2. This is the second ClinCheck that came from Align after I asked for the changes. And you can see I put some attachments on my incisors to derotate them. And you can definitely ask them to be removed during treatment, as I do here, for aesthetic purposes. And you see I have my torque control here to be able to add some lingual root torque, because as we remember, those roots were protruding buccally. So I wanted to retract them, but at the same time, try to do it bodily. And I also have my precision cuts for my class 3 elastics. Now, as we said, Bolton analysis is a tool that it's a good idea to always use, but use it as a reference. So here it says that thankfully, we have a mandibular excess of 3.9 millimeters in the anterior region, which means that it's a suggestion to either do lower IPR or to leave some spaces in the upper arch. Now, for a class 3 patient, I would definitely leave some space and I would communicate it with the parent so they won't be, surprised when I leave some spaces distal to my upper laterals at the end, thinking, is this like bad orthodontics? No, it's a prediction. So they will be able to increase the width of my upper incisors via bonding or veneers with their dentist. And it's also a good idea to, as we said, use it as a communication tool with your colleagues and just share your treatment plan with your, dentist or the patient's dentist in order to make sure you have the best possible aesthetic result at the end. Now, Invisalign again says that Bolton analysis tool is a reference information, right? Always use it, but I wouldn't use it per se just to make sure that I apply 3.9 millimeters of IPR, because it says here it's not directly correlated to the amount of IPR that a specific patient may require. We must remember that the Bolton measurements come from a relatively small sample of Caucasian males. So you cannot definitely apply it, to every patient, but use it your discretion and use it as a tool. Make sure you understand there is a discrepancy and then distribute it accordingly. And your ClinCheck will let you show it to your patient. Now let's take a look at the ClinCheck from different views. And I always, as I said, use your staging to make sure that what you're asking for is predictable. So this is a staging that is, let's say, a reverse icon of a distalization. So if we're distalizing, you will see your staging going like that, like a V. Now here it's like a reversed V, because I'm starting to move my first premolar, and then I'm moving my second premolar, and then my first molar and my second molar to make it more predictable. So as you see here, we're moving one tooth at a time, backed up by class 3 elastics. And those are the occlusal attachments I was telling you about, that we are using them as bite blocks. So I'm not putting any resin here, just the attachments. The thing is, I asked the technician to remove it after stage 17, when the supposedly the anterior crossbite was corrected. And again, I wasn't that experienced, and always make sure you take into consideration there might be some lagging. So I saw here that, okay, my anterior crossbite is corrected. Please remove those attachments. And my idea was to help my patient. I thought they were going to bother him while occluding. Well, to tell you the truth, none of my patients ever complained of such bite blocks. So I would have treatment planned the case again. I would have left those attachments a little bit more. And this is the reason why I needed to actually retake impressions, as we will see. And I would take a look at our tooth movement table, and you can use this tool to see all those measurements. Those are, as I said, the degrees and the millimeters that each tooth is moving. But again, think about it as the final tooth position, and it says nothing about the anchorage that you need to be able to apply all those movements. So those are the movements of just one tooth. Imagine the tooth, in space. So in comparison to the previous measurements, I'm just now moving to the buccal, to the lingual, my, let's say 42 by only 2.1 millimeters and not 3.5 or 3.7. That was the measurement before. And at the same time, I'm adding, because those are crown measurements, so I'm adding some lingual root torque to make sure I have the root in the middle of my bone and the symphysis. And again, this is how I treatment plan here with the bite blocks. And you can definitely put your attachment on the buccal side for your class 3 elastics. Talking back then with the clinical advisor of Invisalign, he proposed I put them on the lingual to be able to have them closer to the center of resistance as I'm mesializing the tooth, because I didn't want to have any tipping. Okay, so you can definitely put it on the buccal or on the lingual, or you can use both sides of the teeth. And again, this is the lower, where I'm applying all those attachments here as bite block effects. And you will see no attachments on my posterior teeth. Again, if I was to treatment plan the case, again, I would definitely put some attachments on my molars, even for anchorage reasons. Now, progress pictures are a very good thing to do for your own self-criticism too. So I took my progress pictures on aligner 17. This is what was supposed to happen. This is what was happening. And mainly because the patient wasn't that cooperative with his class 3 elastics, but having a digital treatment plan is another good idea to show them and, reinforce their cooperation that, without your help, I'm not going to be able to treatment plan and treat this case correctly. So I showed him, this is where we're supposed to be, and this is where we are. And actually, that was the stage that those biturbos, those attachments that were placed on the occlusal surfaces were removed from my aligners. So I thought this is still very traumatic for my patient. So I decided not to keep on with the rest of the aligners, but again, take new impressions back then and do another ClinCheck. So those are my additional final aligners. So I'm asking again for more attachments on the occlusal surface, and you will see those extrusion attachments that, as we saw before, are hierarchy number 1. I asked them to be placed during the final stages. Number 1, because extrusion is a very difficult movement to be corrected with aligners, because the aligner is very good at pushing teeth, not pulling teeth. So you cannot take a tooth and pull it down. That's why we're using attachments. Otherwise, you'll just see the aligner hanging down. So number 1, I wanted to do the most unpredictable movement at the end. And number 2, because here, as it says, it's a simulation. So gingiva cannot be nicely simulated. And I liked how my gingiva looked around this stage. So I thought maybe I wouldn't even need those final aligners to extrude those teeth if I'm going to be satisfied with how the gingival levels will look like. And remember, those teeth were going to be bonded. So you can actually send your patient when they're, let's say, on aligner 15 and you like how your final position of your laterals are, send them to the dentist and discuss them about it. Now you see I have some IPR on the lower arch, which I didn't actually perform. It's called fake up IPR, but I always monitor with the floss. The purpose behind that is that the patient had some black triangles here. So if I would see that he had contact points very tight and still black triangles. I would just use my stripping tool, maybe do 0.1 millimeters to have better contact points and closer to the cervical region to avoid those black triangles. But eventually we didn't need them, but I treatment planned them. And this is the ClinCheck for my additional aligners. Again, we're keeping the mesialization, and that's why you see all those teeth moving. All those arrows that you see here are attachments coming in or coming out. So those are the attachments on the occlusal surfaces of my posterior teeth, helping me with bite block effect. And you can see the extrusion happening at the end. And you might not even consider doing it. It's up to you. So you can stage, because this is different staging, you can stage your treatment as you wish. If I wouldn't have told my technician, maybe they would have done the extrusion from stage 0, which is probably more unpredictable, and I might not have liked how the final position of my gingiva will look like. Now, always use, again, your tooth movement table to make sure you realize that what you're asking for is realistic. And there were, as you might have seen, some attachments on the lower incisors on the lingual side that actually act as bite blocks. And this is the protraction of my incisors, doing it in groups of teeth. Those are, again, just attachments on the aligner. I wasn't going to put any resin there, just asking for a bite block effect for my patient to be more comfortable. Again, I opted for attachments on the lingual side, and you can see the protraction. We are going to leave that space for bonding, and then I'm protracting the posterior teeth. And it was kind of tough to get my second molar in with the impression material. As I said, he had a gagging reflex, but on growing patients, I see those teeth tracking quite nicely, even if they're not fully covered with the aligner. Now with scanning, it's much easier for the patient. And again, bite block effect here, and just, the aligner, and I'm not putting any resin there. So this is our final result 1 year after treatment, and we were following the older protocol back then, switching the aligners every 2 weeks. For additional aligners, we were switching every 10 days. Now I'm switching every week, unless I have a perio patient or maybe difficult movements to achieve. So we didn't use the final aligners because I like how his gingiva looked like. I didn't want to extrude that tooth anymore and get that gingiva level down. Then he would probably need some gingivoplasty. And take a look at his perio condition here. Besides here having like a small gingival issue with brushing, otherwise I cannot see his roots because we applied with lingual root torque all the movement that we needed to get them inside the buccal bone, and nice shape of the upper and the lower arch. And again, look at those incisors moving back, and trying to imagine what would have happened if you had just approved the first ClinCheck. And again, imagine and think about the first ClinCheck as a basis, and then you have to apply all your expertise and your orthodontic knowledge to make it, scientifically sound to you and orthodontically reliable for your patient. And that's after bonding. And again, here, still trying to convince the parents to extract the third molars, and he extracted them, as I said, after we finished treatment. And that's his final Ceph a year afterwards. And look at the profile change, just amazing. I'm always grateful for being an orthodontist and seeing changes in my patients and his measurements. Still a little bit shy, but totally different smile, and with his teeth bonded. And his result is very stable. We have finished, I think it's like 5 or 6 years ago, and always a good idea to compare what the ClinCheck showed initially, what the ClinCheck showed finally, and you will see a discrepancy between the line here, the occlusal level, because as we said, as I said before, I prefer to stop before the final stages of treatment and just bond the teeth through the dentist and not just extrude his teeth. Now, so conclusion of the first case. This is a very nice mountain place in the northwest of Greece. Again, I tried to put some mountain pictures because, as I said, most of the people think of Greece in terms of islands, and I will more than be happy to show you around if you come and visit my country. So let's get back to Invisalign again. And this is my second case that we're going to discuss about. And this is a light case. So for people that are starting with Invisalign or in countries that is not that easy to provide treatment options that are quite expensive, I would think light cases is the way to go. So light case means that you have movements restricted to only 14 stages. And yes, right now you can ask for 14 additional aligners and 14 more, so 28 additional aligners. That doesn't mean that you can do a case for, let's say, 40 aligners. So if you want to do a light case and the final results look good, you have to squeeze all those movements in those 14 stages, and the technician should be able to apply those. Meaning that, yes, I can ask for additional aligners, but that's for finishing up, for touching up the case. But always remember, you only have 24 months to finish the case. Otherwise, the case will close. And always remember the limitation. So I have 0.25 millimeters of millimetric movement per aligner and 1 to 2 degrees according, depending on the movement of, let's say, rotation or torque per aligner. So if I'm having a rotation, let's say, of 40 degrees, obviously I cannot fix it within 14 stages, and they will let you know that this is not a light case or it might be a light partial. But if you can, let's say, the clever way, try to accomplish all those movements, at least on the ClinCheck in 14 stages, you know that you have 14 and 14 more aligners to be able to finish up the case. You might end up seeing some unrealistic movements though, with light cases, let's say distalization of the whole segment, because yes, they can distalize 0.25 millimeters. Let's say you can distalize 1 millimeter of your upper second molar. That's only 4 aligners. But then you need to distalize your first molar and then your second premolar and then your first premolar. And if you do it sequentially, it's more than 14 stages. So your technician might provide you a distalization of the whole segment. This is not going to happen though, unless you're having mini implants. So make sure you pick up those unrealistic movements because your technician is trying to make you happy, but you won't be as happy as when you approve the ClinCheck when you see those things not happening in reality. So distalization might be a little tricky. Same as elastic simulation. You might ask your technician to simulate an overjet correction of 4 millimeters with class 2 elastics, but is this going to happen? So you are the judge of that. So a judicious combination of reciprocal movements, as I said, clever thinking, try to do all those movements that you can achieve in 14 aligners, and you might be able to provide your patient with a light Invisalign treatment that will end up perfect. And IPR is a tool. It might help you, get away with a few issues with crowding, but again, it's up to you how much IPR you feel comfortable doing on your anterior and posterior teeth. And also you can alternate your velocity of aligner change. So if for a light case, we're switching every week, then we're having 14 stages, meaning 14 weeks. If I'm going to use class 2 elastics, I won't have enough time for them to, act. So you might want to tell your patient to switch every, let's say 10 days, or maybe even every 14 days to make sure you apply all the force that you need. So this is the second case, and this is actually not a light case, but I was kind of, I would say, bold and inexperienced for that patient, because he said, I don't want to have braces. Can you please help me do it with aligners? So I said, yes, we'll give it a try, but this is definitely a borderline case. It came out very nicely, but with a lot of anxiety back then, because up to, I think, 2 years ago, for a light case, you were able to ask for 14 more aligners. So I had 28 aligners to finish up the case. So he's also a class 3 case, and this is quite rare in Greece, but it's an interesting case to show. Full crossbite, and you can take a look at the asymmetric type of the arch. So I knew I can do some dentoalveolar expansion here, not skeletal expansion. Class 3 canines on sides, and not a lot of crowding on the lower arch. So nice facial aesthetics. I definitely wanted to broaden his smile and have a better, arc on my upper arch after finishing treatment. His pan was normal. He had some dental work to finish, and that's his class 3 skeletal profile with his end-on occlusion. And again, we wanted to do a camouflage treatment, no surgery here, obviously. And let's see his first ClinCheck. So this is the first video that came from Align when I said I want to do a light case and try to finish, class 1. So you see a lot of IPR because obviously we cannot procline those incisors. No class 3 elastics back then, no precision cuts because it wasn't one of the tools you could use for light cases. So as we will see, I used class 3 elastics, but we had to trim our aligners. Teeth moving, all the teeth moving at the same time, because usually when you have a light case, you don't have many stages to work with. So you do wanna, squeeze, as I said, all the movements, but this is not, my definition of a symmetric arch. I'm not sure what the technician was thinking, but they haven't changed the upper molars. They haven't corrected the crossbite. And as we will see the lower, you can take advantage when you're having a crossbite case and constrict the lower arch a little bit more. So you can have better control of the crossbite correction, not only by expanding the upper, but at the same time, constricting the lower. And now we can see all those movements here. As I said, a lot of movements happening, but not much on the upper molars that we actually want to have the crossbite correction. And again, that's up to you to realize it's not happening. You can definitely see it on your ClinCheck, but you can actually see it on your numbers too. So let's take a look of what's happening now. And I've asked for, full crossbite correction of my molars. And I didn't want to have a class 1 canine because they gave me a class 3 canine before. I use the IPR initially provided because I know I'm going to retract my lower incisors. And let's see what's happening on the buccal segment. So yes, we can achieve now a class 1 canine by asking the technician to mesialize the canine and distalize the lower canine more. And at the same time, I'm having a correction of my crossbite, and I'm adding a conventional attachment on my molar for better control. And now I see it, but then I couldn't see it. Look at that lingual cusp hanging down at the end. That's like a sign of premature contact and of a posterior open bite. So again, we learn from our mistakes, and when you're expanding your arch, always consider adding extra buccal root torque on your molars. Otherwise, you might see that molar moving supposedly bodily, but what it's doing, it's just tipping. It's like tipping with braces, because the aligner is pushing from the inside, and you're going to have extrusion of your lingual cusp. So you want to upright your molar by adding your extra buccal root torque. But as I said, if you don't know something, you don't see it. And back then, I didn't know, I didn't see. At least I have a more symmetric upper arch. It looks better. So I don't have my molars, being left towards the lingual. And I'm also asking for constriction of the lower arch. And again, if I would have done it today, if I would do it today, I would constrict my first molar from stage 1. So there's no reason why wait till almost half and towards the end of treatment to start constricting the lower arch. And this is what happened on aligner 6. I have anchorage loss because I was wishing for some plastic magic, and I told my patient, you know what, we're not going to use class 3 elastics from the beginning. Let's see what's happening with the IPR on the lower, but obviously this is not going to work because he's end on, when the actual ClinCheck showed that on aligner 6 I should look like that. So a little bit of overjet correction, and I had no correction here. My patient was informed from the initial treatment plan that he was going to be asked to wear class 3 elastics full time if required. He was very cooperative, and that's what we did. As I said back then, I couldn't ask for precision cuts. Right now, for your light cases, you can definitely ask for precision cuts or button cutouts for the aligners to be fabricated. And back then I couldn't, so we just bonded a metal button on the posterior teeth and an aesthetic one on the lower canine, and we had to just cut the aligners, all the aligners, the remaining ones, and he was wearing his class 3 elastics. So this is aligner 13. I had one more aligner, but I prefer to just maintain it because it took some time to send back then the impressions, and then the additional aligners. I was kind of worried that he might break his last aligner. So I said, let's take impressions on aligner 13. Now with a scan, we receive our aligners much quicker. So I had some premature contacts there, and you can definitely see that lingual cusp, the palatal cusp hanging down, and you could actually see it on the ClinCheck, but I didn't observe it. So I had some premature contacts there and here. So I had a posterior open bite, and thankfully I had another series, the second series of my 14 aligners, to be able to correct what I actually iatrogenically did. And what you see here is there are no contacts at all. And again, I couldn't ask for a virtual bite jump back then. Now you can ask for a virtual bite jump for light cases. So what I said is just add buccal root torque on my upper molars. And since I was anxious to achieve it in 14 aligners, because that was it, I only had 14 and 14 aligners, I placed 2 attachments on the buccal and on the lingual of my upper molars. And if I go back here, take a look, you will see those green dots. Those are the premature contacts that they were here and on the premolar. And again, the attachments on the buccal and on the lingual to torque the buccal, the palatal cusp, and give some buccal root torque on my molars. And as we will see, always use your occlusal contacts here. Here, it was the green dot of the palatal cusp, not allowing my buccal segment to settle in. So that's what I told the technician. I want to, get rid of my premature contacts by adding buccal root torque, not extruding my molars, which is a more unpredictable movement, but by extruding my, just a little bit, my buccal cusp, and actually intruding my lingual cusp. And as I said, this is a light case, so you will see movements happening on all teeth. And you can see that palatal cusp coming up, and that's the premature contact being eradicated. So just buccal root torque and also lingual root torque on my upper incisors. So stage 14, actually my upper and my lower teeth are in the air. And if it was today, I would just get a virtual bite jump and get good occlusion. So here is the 13 aligner. And as you can see, I'm adding for my buccal inclination 8.3 millimeters of buccal root torque or lingual crown torque. So I can get my cusp uplifted. And again, you have to ask for that. Otherwise, what you will see happening is that your technician will try extruding the buccal cusp, but it's not the buccal cusp that it's at fault. And also, as I said, extrusion movement, it's much more difficult, try to avoid it. So instead of just extruding the buccal cusp, just upright your tooth by adding your torque, but you have to specify that. And this is our progress pictures. And he was at the time wearing his class 3 elastics just at night. And that's our final result, again, within a year. And I would just have corrected a little bit the torque of the premolar, but he was satisfied with that. So good occlusion. And if you see just like 0.5 millimeter of open bite, within a month of not wearing full-time aligners, it's being corrected. So I wouldn't worry about that. And again, this patient has been stable for more than 4 years, and much nicer smile, broader smile. Profile, not much of a change because it was mostly dental movements. And he also started extracting his third molars because of pain. And we have some even overcorrection of the overjet, nice straight profile, and our Ceph measurements. And that's before and after. Just with aligners within a year. And again, this is, I wouldn't consider it a light case, but I just wanted to showcase what you can do if you try to judiciously use the maximum you can do with your 14 aligners. So just a year. Obviously, if the patient can afford it, if you can offer a full case, it's less stress on you and more advantageous because you have 5 years to keep asking for additional aligners. But that was mostly a financial situation here, and it was a challenge for me. So I would think it was, it worked out fine for both of us, but just with a little bit more of a stress. So just to sum up, so we can have also some time for questions, if any. Just make sure when you're moving into the digital world with aligners, don't forget your biological principles, but you have to just change your pace and think about biomechanics in a different way. So always evaluate your initial ClinCheck because that's your beginning. You want to treat the actual patient. Make sure what you treat is what you see on your ClinCheck. You have obviously to have clearly defined goals in your mind because you are the one responsible, not the technician. So the more detailed is your treatment plan, the more clearly defined your goals, the better you can explain it to the technician, the better ClinCheck you will receive. When you're communicating with your technician, try to avoid generic terms like give me a class 1 occlusion, perfect overbite overjet, derotate tooth. Try to be precise, even with degrees, with millimeters, with staging, because they're not in your mind. They don't have orthodontic training usually. So try to help them out to help yourself. Pick up any unrealistic movements, and this has to do a lot with experience, but it will come. And I would definitely want to congratulate the ortho department for organizing so many webinars, from speakers from all over the world. And each one of us has a small, piece to add. And I would definitely try to watch as many webinars as possible now with coronavirus, that everything is digital. So if we are able to pick up any unrealistic movements, obviously then we can differentiate what's virtual, what's clinical, and try to modify the staging to make it more predictable. The attachments, we just said a few words. It's again a big chapter, but I think it's one of the most important things with Invisalign, the correct selection of attachments. We should evaluate of use, so not just taking a look at the front, but left, right side, use your superimposition tool, use your Bolton analysis. Pay attention to the tooth movement table and its implications, meaning all the movements that you see on each of the teeth that you're moving, but also the implications, meaning mainly what are your anchorage? Are you going to tax your anchorage because you're moving your teeth? So try to make sure you understand what every tooth is actually doing to its neighboring teeth or to the arch. And finally, do not accept a suboptimal ClinCheck. Sometimes we might get tired, or we might talk to a technician that doesn't really understand what we're talking about. But if you accept a suboptimal ClinCheck, you will definitely get a suboptimal final results. Take your time and, write your notes. Sometimes you might even ask for, a technician change. And it's not called practice, out of luck. We try to be ethical with our patients, but I think the more experienced we become and the more knowledge we share with colleagues from all around the world, the more our, ortho practice gets better, and we offer more advanced results to our patients. So finishing up with the Santorini view, I would like to thank you very much for your attention. And I think we're now open to questions. Thank you.
Thank you so much, Yona. That was such a wonderful presentation.
Thank you.
With both the cases. Second case, especially, I would say that you have turned into really a light case and you got an amazing result. Sorry. But as you rightly said, that everything has to be built into your first ClinCheck, because later on you will not be able to change the ClinCheck what you have initially agreed upon, right?
Sure. And I do think that's the key point, because it's not like with braces that you see your patient and you might not have thought of something, or you see a side effect and then you switch and you fix it. With a ClinCheck, you want to have the final result, on your mind from the get-go, because you'll get all those aligners. Maybe you get like 60 aligners. You don't want to start rescanning your patient on aligner 15 because you realize, oops, I missed a key point. But we are, again, we're learning, we're humans, and I feel very responsible for my patients. And that's why I think it's a good idea to start with easier cases. It's a different tool, and you have to get used to thinking digitally.
Okay. When we try to achieve everything in the light case with the ClinCheck, first ClinCheck, what happens is, I have seen personally that we might increase a little bit of velocity in every aligners.
Right.
So,
you get the maximum velocity.
yes.
You cannot ask for more. Even if you ask for more, you'll get a light partial.
True.
Light partial is not a good idea to accept, because with light cases, not named partial, you can work around it and make it maybe a little bit better than the actual first ClinCheck. With light partial, you're stuck. You cannot, let's say, derotate more than you got on stage 14. But because what you definitely said, that you feel like you're moving too quickly, that means you are going to have some side effects.
Yeah, true. And one more thing, like sometimes too, economical aspect is a big aspect, even in Indian subcontinent, because it's a huge money, right? Now what happens is, I started giving an option of pre-aligner or post-aligner, little bit of attentive orthodontics to a few of my patients, because during their most crucial time, either they're getting married, or they're having a job, or they're having something very important in their life. So at that particular point of time, they might need aligners. They don't need braces. So what happens is, so do you agree to that? Like sometimes.
I think, again, as orthodontists, we are committed to our patients, right? And I don't think it's a bad idea to be innovative.
Right.
And you can switch between braces and aligners, or maybe you can do expansion first with a hierarchies, a quad, or a removable, and then by the use of another appliance or a distalizer, you cut down.
Sagittal first.
Yes, you cut down on the number of aligners that you are going to ask for your patient. So this is an automatic transformation of a full case to a light case, or maybe to an I7 case. Well, right. I7 is for very, very easy cases.
It's like very easy. It's mainly for relapse cases, I would say.
Yes, I would definitely say. Or maybe for a very lucky patient that comes and they have like a lateral and they're getting married and they want to have perfect pictures. But I would definitely do that. And I actually do it with my growing patients, because my My PhD is on class 2 malocclusion, which is very prevalent in Greece. And we used removable appliances. So we use a Holey and then a crib and then braces. And now just to finalize the occlusion, but right now I can sometimes just correct the class 2 into a class 1 and use aligners. But I don't use aligners to correct my class 2.
Got it. Okay.
So yes, you can. I definitely agree, and I think the more you know, the more you can combine things. Or sometimes I even did it yesterday. I had a patient with bad oral hygiene with brackets, and I just couldn't convince him to brush. And I told him in front of the mother that I cannot be responsible if you cannot, discipline your child. I'm not here to argue. I'm here to advise, and my advice is brush. So if you're not brushing, I'm taking the braces off and you will finish with aligners. So I'll provide him those 7 aligners to finish up the case. Obviously, he has to brush with aligners.
I know.
But he's a teenager. So I even told him, we're not going to charge you for that. I just wanted to finish it nicely. So this is another tool in your armamentarium to offer. That's my take on that, to offer more options. And to some patients, there are better options, and Invisalign is a great option for patients doing MRIs, for patients living abroad, for patients with medical issues. It's excellent. It's excellent. But I do think the main issue here is the financial. It's not if it's working. Yes, it's working. That's why we're talking about it. Otherwise, I wouldn't have done it. But it's mainly the financial issue and how you can work around it. So maybe you can be, as I said, more innovative and work around it yourself.
And you'll be on a driver's seat rather than letting technician doing it. So that's the key.
Yes, of course. And with in the States right now, you have all those male aligners. Patients don't even see their orthodontist. And I tell my patient, you have to go to your dentist not only because you need to do your profit, but they might pick up a lesion. I had a patient with an osteoblastoma that I saw the lesion myself. And I was like, wow. And what if that had happened during coronavirus and I hadn't seen the patient for 3 months?
I know.
I cannot monitor with my iPhone, and no, I cannot do that. And I like being a scientist, first of all.
So how frequently you see your Invisalign patients?
It depends where they are. So if they are outside the city, I would say every 3 months. I had patients coming in every 6 months. Now I even have every 9 months because they were supposed to come for Easter and now they cannot even come for summer. It's a little bit stressful, but if they are living in my hometown, they might come every 6 to 8 weeks.
Okay.
And if it's an Invisalign first, I might monitor the patient every month because teeth shift.
True. And in first case, you had kept occlusal attachments.
Right.
So
that wasn't my idea. It's Sriram. I think he's from Pakistan or India. He's one of the cleverest clinical advisors I ever talked to, and I've learned a lot. He's not with Invisalign right now. So he was the one that discussed about bioblocks, and then you're like, why didn't I think about it? Well, you cannot think about everything yourself. So he said, let's ask for occlusal attachments that you don't build up. So I don't put any resin there.
Yeah, so you will have something like what you have.
You have like bubbles.
Bite ramps.
Bubbles, exactly. It's like having a normal bite block. So you have those bubbles and they just take the aligners out for eating. I actually have a good friend of mine that he's putting resins on, but I think it's a little bit tough to, clean it afterwards and for the patient to brush. Right now you can do it yourself. You can put just vertical attachments and you can ask even for 3 or 4 of them. So make it like a platform. So I used it there. Right. Instead of, because there it was like biting just on a small surface. Now I make like 3 or 4. It's an occlusal platform and it's very convenient. And you can even use it for, let's say, a correction of an anterior crossbite of just one tooth. Wow. You can even use bite ramps or you can use your occlusal attachments. It depends on the case.
Right.
if
Okay.
it's a deep bite or an open bite.
We have a question. Few questions I already answered. The question says that Dr. K. Srinivas Kumar Karnam, can moderate and severe crowding cases be treated by literally aligners only? And what extent transverse discrepancies be treated by light aligners?
Sorry, I didn't get the last one. If the moderate extraction cases, if they
Yeah,
can be
and
treated?
up
Yeah,
to
sure.
what extent you can actually treat the transverse discrepancy by light aligners?
Okay. So first of all, I would answer like I got an answer from dental school and I was getting frustrated when they were answering me like that. I would say, it depends.
True.
In orthodontic
Objective.
department, every question I would ask as a first year, it was like, it depends. I'm like, yeah, but that's not helpful. Eventually I understood it is helpful. It's 0.25 per aligner. So you need 4 aligners for 1 millimeter. That means that you can get for, let's say, 5 aligners or let's say 5 millimeters of expansion. But are you comfortable with 5 millimeters of expansion? It's up to you. So you can count 0.25 multiplied by 14, and that's your answer. But that's your mathematical answer. The biological answer might be different. For light cases, you can even use your cross elastics. I didn't use any cross elastics because I didn't want to have any extrusion. But that's the maximum that you can get, not only for expansion, for distalization, for extrusion, for intrusion. But with light cases, I will be a little careful with staging. So they do a lot of things all over the place. They can expand and distalize and intrude at the same time. That doesn't mean that because they are showing you on the screen, it will happen. So that's my take on that. For moderate cases, I would definitely say you can treat it with light. If the rotations, because usually it's incisor rotation that you have, if your rotations can be treated within 14 aligners. So if it's 28 degrees, so 2 degrees per aligner, 28 degrees, yes, you can do it. And what I tell my patients is, I'm showing a ClinCheck with 14 aligners. You will need more. I just tell them, so they won't be, looking at their watch in 14 weeks saying, I'm done. No, you're not. Probably not. So 28 degrees of derotation in 14 aligners, it's in theory, you can do it, but it might not happen. If it doesn't happen, you can rescan and ask for more aligners and they won't charge you. And that's, the way to think behind that. Same with expansion. So in 4 aligners, you'll get 1 millimeter of expansion, right? So you get like 14 aligners. Will you get all that expansion needed? Probably not, because you get a lot of tipping, but you have 14 more aligners. And with light cases, I'm also very careful with attachments. Because if it's not going to work within your 14 aligners, you don't have that many aligners to correct it. So if I have, let's say, if it's a deep bite case with rotation of premolars, I usually don't use my optimized attachments on premolars because I won't get any extrusion with my rotation attachment. Because my premolar needs to be extruded and rotated. It won't happen. So I will use a big, horizontal attachment or maybe tilted, 45 degrees to get the rotation at the same time. So it comes with practice, but I would definitely take advantage of Invisalign's, surveys that they provide, that you can make appointments and upload your case and discuss it with whoever is responsible for your region. And some of the people there are very smart. They might not be orthodontists, but they know the software.
True.
So I'm thinking orthodontically, but they're thinking mathematically. So the combination is really helpful. And you can always learn a small hint, and next time you use it.
Thank you. Thank you so much.
You're
Dr.
welcome.
Loanna. Such a wonderful thing. So last question I would ask from my side. Generally, in extraction cases and in the other cases where the optimized things been activated, like G6 protocols and all. So personal preference, do you go with those protocols or you change it to your conventional things?
It depends. No, I'm just kidding.
Got it. I got the answer.
I'm just kidding. I would say for extraction cases, I would, in almost all cases, go with a G6. It's very reliable and it gets me, let's say, 80%
Of things.
to the final result. Because what the optimized attachment does is it totally gets a good engagement every stage on the active surface. With the conventional attachment that I place, it's just a bump on the tooth. It won't get, all those forces, all those moments. I just get a bump and I try to put the force perpendicularly. It won't happen throughout treatment because it doesn't get adjusted. With the optimized attachment for every stage, I don't do it, the software does it, it adjusts the forces. So for extraction cases, I would definitely suggest you use the G6. The problem is if you want to use elastics at the same time, because if you want to distalize, let's say your upper canine, which is high up and rotated, and you want to use elastics, then you have to get rid of one of the two optimized attachments and then you're losing on the moment. So what I might do at the time is I use the optimized, and again, I'm having a specific case in my mind, but it depends on the case. So it will get me towards the end, and then I'll tell the patient, you know what, after a liner, maybe 25, 30, I'll rescan you, and then I might put my vertical attachment. Okay. Or I might put my own attachment for, let's say, 10 stages to get that derotation done, and then say, please apply G6 protocol. But I really like it. Even in very difficult cases, I would take a look at those small attachments and say, oh my God, are those going to work? And they did.
They do, because they are optimized and a lot of
they're optimized, and
yes.
it's the change in the shape of the aligner that gets applied that you lose it with your conventional attachments, and I cannot do it on my own. So I definitely will go for it. I'm not in favor of G5 all the time though for extrusion. And in my clinical preferences, I also ask for the biggest possible optimized attachment because you have that option. I like the surface, and I always tell my patient that, you know what, those attachments are definitely necessary, and I'm sorry if you don't like them, but I will put them. Otherwise, you're not a good candidate. It won't work.
True.
But they look better, especially on the lateral that I put the 45-degree, the beveled horizontal attachment. It looks horrible on the profile. It's the only attachment they can see. But sometimes I will use it because the lateral is a weird tooth. It's
very weird.
Yes, it's small and it has
the most difficult with your
It's the most difficult. I totally agree, and it's right in front of them, and they look at it in the mirror every day. So I'll tell them, if you want it corrected, I'll just give you a big attachment.
Thank you. Thank you for such a great insight, and thank you so much on behalf of all the attendees.
Oh, thank you for the honor. Thank you. It was a pleasure.
Yeah, it's my pleasure too. Stay safe.
Thank you. You too.
Hope to keep in touch.
Thank you. We will. Thank you. Bye-bye.